Hi everyone, let's start our review for our final. And we're going to start on page 153. And we're going to talk about the types of shock. What are the 4 types of shock? So the 4 categories of shock are, and this is right under types of shock in your book, the 4 categories of shock are hypovolemic shock, which is low circulating volume, bleeding or hypovolemia due to dehydration, cardiogenic shock with low cardiac output, so they've had massive MI, obstructive shock, where they have occluded vascular pathways like a pulmonary emboli, or vasogenic shock, where they have a massive vasodilation. So they have the same volume, like a wine glass has volume. Then you take the volume from the wine glass and pour it into a tall water glass. It doesn't look like very much, but it's the same amount. It's just a larger glass. So the blood vessels are larger, but the same volume. And that would be your vasogenic shock. Okay, let's turn to page 351. And we're going to look at page 351. And we're going to look at our fight or flight. Turn to page 361. Be sure you turn to the right page, right? 351. So at the bottom of the page is table 21.1, effects of sympathetic and parasympathetic stimulation. So we need neurotransmitters epinephrine and norepinephrine to go from neuron to neuron and give us the sympathetic stimulation. These are the responses that are sympathetic to our needs. We're a caveman hunting for a tiger, and it's dark out. We're hunting for food. We see a tiger. Are we going to fight it? Are we going to run away? Flight. So what happens to our body, though, during that time of fight or flight? Well, it says in your book, your pupils are dilated. You have an increased heart rate. You have an increased blood pressure, reduced peristalsis because they're keeping the blood flow to your heart and lungs, and pupil dilation so you can see in the dark. So that's your fight or flight reactions with the release of epinephrine and norepinephrine. So let's go to page 365. And we're going to look at those 2 pictures there at the top of the decorticate and decerebrate posturing. And the page before that talks a little bit about it. And it says, an increasing pressure is exerted on the cerebral tissue above the midbrain, a pattern known as abnormal flexion or decorticate posturing. And if you turn the page, the decorticate posturing is A. The arms come up. And that's due to increasing pressure on the tissue above the midbrain. Abnormal flexion, decorticate posturing. And the picture is A. Okay, let's go to page 361 and talk about your job as a nurse if a patient has a lumbar puncture. And this is table 21.6, diagnostic test and procedures. So the test is lumbar puncture. Your post-procedure nursing care is the risk of headache may be reduced by lying flat for a specific period after the procedure. So make sure your patient lies flat after a lumbar puncture. All right. So let's talk about now page 366, not too far away. 366. And it's at the bottom of the page. Well, we were just on 366, weren't we? Just the time before. And we have those two pictures of the people. Go down to the bottom of the page, and it talks about, although it's extremely important to monitor vital signs in the neurologic patient, remember that changes in pulse, respiratory pattern, and blood pressure are late signs of increased intracranial pressure. The combination of hypertension, bradycardia, and a widening pulse pressure is known as Cushing's Triad. So the three symptoms that are characteristic of Cushing's triads associated with increased intracranial pressure are bradycardia, increased blood pressure, and widening pulse pressure. All right, let's turn to page 365. And we're still talking about post-op nursing care here in the neurologic system. And on page 365, about halfway down on the first paragraph, it says the physician prescribes the patient's position and usually specifies that the head of the bed be elevated about 30 degrees. That is to decrease intracranial pressure. So the head of the bed at least 30 degrees helps reduce intracranial pressure. All right, and we're going to turn to page 379. And we're going to talk about a patient with meningitis. And if you see the picture at the bottom of the page, the nurse flexing the patient's knee and the neck. And if you read figure 22.3, it says positive Koenig sign. When the patient's leg is flexed, as shown, the patient is unable to completely extend the leg. And Brudzinski sign is when the nurse flexes the patient's neck, hip flexion occurs. This is all irritation of the spinal cord or meninges surrounding the brain and spinal cord. Whenever it's irritated, you're going to have difficulties in the posturing or in the signs like that. And that's, again, page 379. So Brudzinski sign, be sure you know that. It's when the nurse flexes the neck and hip flexion occurs. Good. All right. The next one would be page 376. I know we seem to flip-flop around, don't we? But I'm just kind of following, actually, the test. So that's why we're doing it this way. So what is the position of an unconscious patient? Well, that would be under impaired mobility. You see under interventions, impaired mobility. And of course, we're going to reposition and encourage the patient to deep breathe if they're alert. What's really important though, is for us to position the patient in an anatomic alignment to prevent flexion deformities. So functional alignment, anatomic alignment, similar because it's the way we function. It's our alignment for functioning. That's page 366. No, it's not. Page 377. Right? Well, actually, it is on page 366 too, under patient problems, goals, and outcome. Impaired mobility related to neuromuscular impairment. Absence of complications of immobility, contractures, pressure injuries, pneumonia, atelectasis, constipation, urinary retention. but it's important to put the patient in functional position. All right, let's go to page 399. 399. 399. And let's talk about treatment for cerebral vascular accident. So, what is it about aspirin and what is it about Coumadin? Those are two things we need to know about. So, under treatment, it talks about, based on research evidence, the American Stroke Association recommends initial treatment with acetylsalicylic acid, which is aspirin, alone or in combination with Agranox. Also, that same under treatment, we have about Coumadin. So what about Coumadin? What does Coumadin do? So Coumadin, what does it do? Coumadin and heparin prevent clots. Aspirin prevents platelet aggregation and prevent another attack. Coumadin and heparin prevent more clots rather than dissolving them. And that is all on page 399. All right, now let's go to page 401. And it's a drug, nimotapine or nipodapine or Nimotop, calcium channel blocker. It prevents spasms in cerebral blood vessels, but what do you need to do? What's your nursing intervention in a calcium channel blocker? All calcium channel blockers, by the way, because you need to monitor pulse and blood pressure, and you need to hold it, the pulse. If the pulse is less than 60, you need to hold the drug. So that's really important to know. So you want to omit the dose recorded in the pulse rate as the rationale if it's 60 or below. But if it's higher than 60, you're going to give the full doses prescribed. No problem, right? Okay. Now we'll go to page 409, not far away there. Page 409. And we're going to talk about impaired mobility of a patient with a stroke. This is a nursing care plan. We have impaired mobility. We also have potential injury related to paralysis. So let's look at that one. That's the second one. So what is our intervention to prevent injury? Keep the bed in low position with the side rails up. That's important to remember. Okay. Rails keep patients in the bed. The bed should be in low, monitoring the patient. Okay, that would be great. All right, let's turn to page 416. Hanging in with me? And let's talk, we're still in the neurological, cerebrovascular area. The nursing care and the rehab. When is it time for a patient to go to rehab? When they've had neurological deficit. Well, it's right under nursing care and rehab phase, and it says stabilization of vital signs with no further neurological deficit indicates the patient has entered the rehabilitation phase of a stroke. That's important to remember. Okay, let's go to page 429 now. 429, and we're talking about spinal cord injury. Spasticity. See the header past spasticity? So most patients with spinal cord injury display some degree of spasticity or increased muscle tone after the resolution of spinal shock. So spastic involuntary movements after a period of flaccid paralysis announces the end of spinal shock. Okay. Let's turn to page 427. And there's a little bit more about spinal shock too, and it talks about the flaccidity stage. You can see that under spinal shock. But what I want to talk about here is if we go up to, let me find it here. I swear I have them all marked and then bam. It gets confusing, doesn't it? Okay. Page 427. During a neurological assessment, trying to find, oh, here we go. Okay, let's turn to page 428. Sorry, guys. Let's turn to page 428, and there is a table 24.3. The degree of loss and functional capability with injury to each level of the spinal cord. So go down to the very, very bottom where it says L4 to L5, L4 to S5. So if I said L5, we know that that falls into that spectrum, right? L4 to S5. So if the patient can dorsiflex their foot against resistance of the patient's hand, this assessment confirms that cord damage has occurred. And if you look at L4, L5, so if they can move their feet, right, they can ambulate with braces, possibly. I hope that makes sense. Okay, let's go to now page 431. Oh, this is a good one. Drug therapy, spinal cord injury. So it starts with, until the early 1990s, management of the patient with SCI relied almost exclusively on surgical and immobilization techniques. However, the use of methylprednisone to reduce the damage to cellular membrane has become standard practice in the acute management of SCI. And the optimal time of administration is within the first 8 hours of injury. So it, again, reduces damage to the cellular membrane. Drug therapy. Okay. Let's turn to page 434 now. A lot of questions on this one, huh? 434. So go down to that box 24.2. Management of spasticity in the patient with a spinal cord injury. This kind of sounds like another question we had, doesn't it? 434. Management of spasticity in the patient with spinal cord injury. How about your plan of care when considering interventions for the outcome of prevention of contractures in a patient with spinal cord injury? Properly position and splint extremities to prevent contractures. Splints, very important to prevent contractures. It holds their arm into the right position, or leg, or hand, right? Splint. Good. All right, next one. We'll go to, let's turn to page 433. And this talks about coughing technique for the patient. So this is under interventions and adequate oxygenation. It's about the second paragraph. And it starts out, a variety of techniques may be used to help patients with spontaneous but impaired breathing to clear the airway more effectively. These include breathing exercises, assisted coughing. Well, how do we do assisted coughing? Well, it says that in the next sentence. For assisted coughing, apply firm pressure to the diaphragm just below the rib cage as the patient exhales or coughs. So it helps provide so that they don't use the wrong muscle group. Okay, assisted coughing, firm pressure under the diaphragm. Pressure, and they can take a deep breath. Okay, now let's go to page 443. 443. And we'll talk about, looks like sinuses now, huh? So if a patient has runny nose and facial pain, what's the first thing you think about? Sinusitis. So that's under present health. And it talks about, and I actually have it written in here. So facial pain, runny nose, assess nasal drainage, and sinus tenderness. So it's all included in that paragraph there. So sinusitis, you can think about if you've ever had it. How do you feel? You have a runny nose, you have face pain. Okay. Next question, page 453, 453, 453. And we are going to, oh, this is our famous question. This is our famous thing. Well, maybe not yet. How do we install nose drops? How do we install nose drops? Well, it's in the second paragraph there. It says, to administer nose drops, the patient may be sitting or lying down, and the head must be tilted back so that the solution flows into the back of the nose. Also note that the dropper should not touch the nose, because that's contamination. And the patient should keep his or her head tilted back for several minutes. And that's in that same paragraph there. All right. Remember, you can always go back and listen to this over and over again if you don't get it the first time. Okay, 465. 465. So Trach Care. There's your tracheostomy. What How do we do tracheostomy care? It is a sterile technique because you are going into that patient's lungs and suctioning them, right? So it is considered a sterile technique. And if you accidentally touch something, you've got to, don't put it inside the patient. You'll give them pneumonia. Okay. I'm just checking here. Use a sterile solution of normal saline or other solution to wash the inner cannula and then rinse with sterile water. And that is under tracheostomy care. All right. The next one, we will go to page 457. 457. 457. And we're going to talk about here thoracentesis. What's important for you to assess after a patient has a thoracentesis? Well, you can see the picture, figure 25.9 of the patient in a position for a thoracentesis. And notice that the doctor has to stick the needle into the fluid area. They put a large needle into the pleural space. And it's done to remove pleural fluid, blood or air, or instill medication. And that's under thoracentesis paragraph. But after the doctor stuck a big old needle into the lung, what do we have to assess for? We have to listen to those lungs. Be sure they're equal. Be sure the one that they put the needle in sounds the same as the other side. Because what if the doctor accidentally punctured the lung? So assess their lung sounds. Because complications of thoracentesis include, and these are under that picture of the person, figure 25.9, complications of thoracentesis include air emboli, hemothorax, pneumothorax, pulmonary edema. Immediately report uneven chest movements, respiratory distress. So be sure you assess breath sounds after a thoracentesis. Makes sense, right? We're so important. Nurses are so important. Okay, let's go to page 453. We're at the bedside. We're the ones seeing the patient. Page 453. So, 453. Trying to see where that is. Okay, so just above nose drops, just above that, but still under therapeutic measures. So what do decongestants do to the patient? What does a decongestant do? Well, it's a problem because it can raise a blood pressure. Decongestants can raise a blood pressure. So if a patient has hypertension already, and then you give them a decongestant and it raises their blood pressure more, that could be dangerous, couldn't it? So if you have a patient with hypertension, you do not want to give them a decongestant because it increases the blood pressure. Okay, let's turn to page now. Turn to page 470. And that begins upper respiratory disorders. So what is sinusitis? That's the very first thing. Sinusitis is inflammation of the sinuses, most often the maxillary and frontal sinuses. It may be caused by bacteria, virus, or rarely a fungus. What are the signs and symptoms? Classic sign of sinusitis is a headache. So if a patient complains of a headache and a feeling of fullness in their head, and it's similar, sometimes in sinuses, the pain feels like a toothache also. So they probably have sinusitis. And this is under your signs and symptoms. Okay. Now let's go to page 476. 476. And it has a nursing care plan for a patient having a tonsillectomy. Well, under this health history, it's a 20-year-old college student who has had tonsillitis 3 times. Now, this answer isn't exactly, I couldn't find it exactly in your test, in your book. So let me just tell you that, what's the best candidate for a tonsillectomy? Well, so the best candidate is a 23-year-old patient with a peritonsillar abscess, because it needs to be taken care right away, right? They've got an abscess. They're still young, 23. So when you go through this test and you look at the answers, look at each one. Does it make sense? And this is one of those examples where, yeah, okay, it's not in the book, the exact answer. But if you look at the other answers for this best candidate for tonsillectomy, the other ones aren't really the best candidate. So you're going to have to kind of default on this one. All right, let's turn to page 478, next page. And we're talking about laryngitis. So go to the header of laryngitis. And what is the most common reason? What's the most common cause of laryngitis? Well, we know that laryngitis is inflammation of the larynx, right? But what causes it? Well, the number one reason is upper respiratory infections. And you've probably had laryngitis before. And it's an upper respiratory infection, or sometimes voice strain will lead to laryngitis also. Now, there's some other reasons listed there, like smoking, alcohol ingestion, reflux. But I'd like to concentrate on upper respiratory infections and voice strain. But if I had to choose one, let's just choose 2. Okay, respiratory infection and voice strain. All right, the next one, let's turn to page 481. 481. And let's look at complications. This is complications of laryngectomy. So complications of a total laryngectomy with radical neck dissection include salivary fistula, carotid artery rupture, and tracheal stenosis. So their trachea gets stenotic. So that's important to remember. Tracheal stenosis is important in a patient with laryngitis. So the next one we're going to look at is page 496. Seems to me we already talked about this, but we'll talk about it again. Must be important. So we're on page 496. And actually, this is talking about flail chest. Let's go down to medical treatment of a flail chest. Now, if you just want to remind yourself, what is a flail chest? Well, a flail chest refers to an injury in which two adjacent ribs on the same side of the chest are each broken into two or more segments. So what's the treatment for flail chest? Well, they might have to be intubated because they can't breathe. They can't take a deep breath enough to get enough oxygen. So the patient in respiratory distress usually requires intubation and mechanical ventilation because they can't take a deep breath without pain. So they don't take a deep breath, and then they're at risk because they're not getting enough oxygen. So a flail chest patient may require mechanical ventilation. Intubation is where they put the tube down, and the mechanical ventilation is the machine that inhales for them. Okay. Let's look at page 498, next page. And we'll look at interventions of pulmonary embolus. Now, we've talked about a DVT, right? Patient having DVTs. So if a patient has a DVT in their leg, what do we not do? We do not put a pillow under their legs. And if you wanted to find this in your book, it's under, like, if you put on your thinking cap and then go down 2 paragraphs, it says interventions to decrease the risk of further emboli include active and passive range of motion, early ambulation after surgery, anti-embolic pneumatic compression stockings. Do not place cushions and pillows under the legs where circulation might be impaired. So that's important to know. All right, let's turn to page 519. 519. And let's go to, let's see, we're talking about chronic restrictive pulmonary disorders. And on page 519, we look at signs and symptoms. So what are some signs and symptoms of TB specifically? That's a pulmonary disorder, right? So signs and symptoms of TB may include cough, night sweats. That is so classic of TB. Night sweats. Now, I want to put something in here about AIDS. Now remember, patients with AIDS have opportunistic infections, right? And it's not uncommon for an AIDS patient to get TB. So if an AIDS patient does present with night sweats, you've got to specifically go, whoops, maybe they got TB somewhere. So let's think about that, okay? So the symptoms of TB are low-grade fever, night sweats, and cough. And a patient with AIDS and anyone who is immunosuppressed are extremely prone to TB. All right. Okay, let's keep trucking. Let's turn to page 509. 509. And let's talk about, oh, there's that wonderful picture. Remember that? The centrilobular emphysema. So centroacinar, which is the same thing, Emphysema, which is associated primarily with cigarette smoking, affects mainly the respiratory bronchioles. The walls of the bronchioles enlarge, and you can see that picture, that the pink part is enlarged, but the alveoli are intact. That's the specific emphysema, centroacinar, or centralobular. It's the same thing, okay? It's important for you to remember. But it is where we have the walls of the bronchioles enlarge and break down, leaving the alveoli intact. So that's that second picture there. It's important to commit that to memory. Memory. All right, let's turn to page 518 now. And we're going to talk about, this is cystic fibrosis. Cystic fibrosis is unique, right? It's a hereditary disorder characterized by dysfunction of the exocrine glands and production of thick, tenacious mucus. So remember, exocrine glands, not only are they in the lungs, but they're also in the pancreas. So they have pancreatic problems. They have foul-smelling stools, bulky and foul-smelling stools. They lose sodium and chloride and sweat glands. They have that thick cough. But if you go to that second paragraph under cystic fibrosis, it talks about, every day they need CPT. They need, we used to do like a cup, patting them on the back to loosen the secretions. Well, now they have something called a Flutter Device. And it talks about this in your book. It says alternatives to manual CPT include the Flutter Mucus Clearance Device, which is a handheld tool that vibrates and loosens secretions and promotes movement of secretions out of the lungs. So they usually kind of lay with their head lower than their chest. And we used to pound on the back of their chest to loosen the secretions. But this is something new. It's called a mucus clearance device, and it does the beating on the chest so the patient can have the secretions loosened and they can cough them up. And that's in cystic fibrosis. And I mean, think about it. You don't want someone beating up on your back. So this Flutter Device is really much more acceptable by the patient. So now let's look at page 320. I don't mean that. 524, sorry. 524. And we're talking about lung cancer. Small cell lung cancer. So if you notice, actually, if you turn to page 523, just to remind yourself about pathophysiology, there's two major categories of lung cancer. Small cell or oat cell lung cancer, which is SCLC, and non-small cell lung cancer. There's small cell and non-small cell, right? And non-small cell is the most common. So turn the page now and go to the surgical treatment. Surgery for the NSCLC, or the non-small cell lung cancer. Surgical treatment is the treatment of choice for early NSCLC, non-small cell lung cancer. And the goal of surgery is to remove the entire tumor while removing as little healthy surrounding tissue as possible. So we want to remember that. Now, the patient's going to get very anxious thinking about this surgery. So what are you going to do? You're going to be supportive. No fake hope. Oh, you're going to be fine. No, not that. We're going to be supportive. We'll be here when you get back. Your family will be here. We'll be waiting for you. We'll have everything you need. Be supportive. Very important, because they're going to be anxious. So support the patient in preparation for the surgery, right? Knowledge is power, and the more the patient knows what to expect, they're not going to be as scared when they get out of surgery. Okay, now let's turn to page 533, if you will, please. 533. And this is a good one because this is under your complementary and alternative therapies. I say it's a good one because you can't miss it, right? It's right there, complementary alternative therapy. It says, be sure to note any herbal products that the patient uses. Now we're talking about, what are we talking about? Hematologic disorders. So be sure to note any herbal products that the patient uses. Herbs that can affect blood clotting include black cohosh, feverfew, garlic, ginkgo, and ginseng. But black cohosh comes up several times in this book, I think. So remember that. It interferes with blood clotting. So let's go to the next one, which is on page 538. And riddle me this. Now, we've had this question before, by the way. So, under administration of a red blood cell transfusion, box 29.6. So you're going to do all these things. You're going to have the patient counseled, sign a consent. When the blood arrives, 2 licensed people check it with the patient, and they're check the expiration date. Should be started within 30 minutes. And then after that, you start taking and recording the patient's vital signs. Watch for blood transfusion signs. But what if they give you, let's say the doctor said, okay, type and cross 2 units of packed RBCs. How many units can you transfuse at a time? 1. So if the lab sends up 2, you're going to send back 1. Don't put it in the refrigerator. Don't accept it. Tell it, take them back to the lab. You'll call for it when you're ready. 1 bag of blood at a time. Okay? All right. 1 unit, send the other one back until you're ready. Okay, now let's turn to page 545. 545. Anemia. All kinds of anemia. Aplastic anemia, autoimmune hemolytic anemia, iron deficiency anemia, sickle cell anemia, pernicious anemia. What's one thing that's common in all of them? What's one thing that's in common? Well, they're all anemic, for sure, right? So, if they're weak and tired and anemic, they can't do a lot of things at once. They've got to rest. So do an activity, take a shower, rest. Get dressed, rest. Take a walk, rest. So be sure you provide sufficient rest periods throughout the day for patients with anemia. Okay? All right. Page 545 again. And we're going to talk about the Coombs Test. Do you see that? It's about middle of the page under autoimmune hemolytic anemia. It's above iron deficiency anemia. It says patients may appear jaundiced. Well, let me just go back up a little bit. Hemolytic anemia of the newborn can occur after delivery if the mother has Rh blood, Rh negative blood, and the baby has Rh positive blood. So that's one part. Go on down. It says patients appear jaundiced. Patients with hemolytic anemia usually have high bilirubin levels in their blood from all the RBCs being lysed or broken down. Patients with hemolytic anemia have a positive result on a direct Coombs antiglobulin test. Antiglobulin test. Coombs test. So what is a Coombs test? It's for newborns that can develop hemolytic anemia resulting from blood incompatibility to their mother. They would do a Coombs test for hemolytic anemia. Okay, I said that a couple different ways. I hope you got that. All right. Let's go to page 554. 554. This is our favorite chapter, isn't it? She said. I have to keep us laughing because we don't want to cry. All right. 554. So this question is about inflammatory response. What is responsible for initiating the inflammatory response? Page 554. So what is it? Let's look at basophils. So basophils with a B can initiate a massive inflammatory response. Basophils. So they also work with IgE, right? But if I was to ask you what's responsible for initiating the inflammatory response, you would say basophils. Right, let's turn to page 557. 557. And that is passive acquired immunity. What's true about passive acquired immunity? So that's about the middle, just above cell-mediated immunity. It says acquired immunity can be active or passive. And if you go a little bit further, it says passive acquired immunity occurs when an antibody produced by one person or an animal is transferred to another person. So passive acquired immunity is antibodies that are acquired from outside the host and then instilled in the host. So it comes from the outside and then it's given to the host. Does that make sense? Passive acquired immunity. All right, page 561. Page 561. So, you guys all know this one. What is important? So this is under diagnostic tests and procedures. What do we always do before a test? We always check their allergies, especially if they're allergic to shellfish, right? Always check for allergies. You already knew that one. So scans usually involve some sort of dye, and we know if dye is involved, then that means that we have to check for iodine. It's iodine dye, and we have to be sure the patient's not allergic to shellfish. Okay, good. All right, let's go to page 567. 567. I'll tell you what I'm going to do, guys. I'm going to do 50 questions now. I'll stop. And then later on, I'll do the second 50 so that you'll have a break and I'll have a break. But there'll be two parts, part A and part B, or part 1 and part 2. All right. I say that because we're drawing close to that. All right. Let's go to page 567. And we're going to talk who's at the greatest risk for infection and bleeding while their healthy bone marrow is growing back. Page did I say? 567, didn't I? But I see it on 566. Yeah, let's go over there. 566. Middle of the page. It says major complications of bone marrow transplantation and peripheral blood stem cell transplantation include infection, thrombocytopenia, renal insufficiency, hepatic veno-occlusive disease. Infection is a constant concern. So remember, blood marrow, the bone marrow is coming back, hopefully, after a disease, leukemia, stem cell transplantation. It's coming back, but until it's back all the way, they can't fight infection. So that is a big concern. Patients are at a great risk for infection and bleeding while their healthy bone marrow is growing back. Infection and bleeding after a bone marrow transplant. It's important. Okay? All right. Now let's go to page 555. 555. 555. All right. So this is immunologic system introduction. Let's look at the spleen. What does the spleen do? Well, the spleen is located in the upper left quadrant of the abdomen. Like the lymph nodes, the spleen filters microorganisms from the blood. That's important to know what the spleen does. It filters microorganisms from the blood. All right. .583. Sorry, I'm not a fast turner. You probably are. 583. So look, we are under immunologic disorders. Opportunistic infections, table 32.2. So the very first bacterial infection listed there is bacillary angiomatosis, or BA. So let's look at the mode of transmission. Transmitted by cats and their fleas. So that's important to know. BA. And a patient with HIV, it's not unusual for them to get that. Right? Because that is this is under the opportunistic infections that AIDS patients can get because they're opportunistic. They find a opportune patient whose immune system is low, and that would be a patient with HIV. So BA, cats. I find that cats are not good for patients with HIV because they carry a lot of disease. All right. Now, let's look at page 591. Hang in there, guys, a little bit longer. Now, I know this is under key points of the immunologic system. Well, sorry, this is where I found it. So it is the second column under key points, and it talks about the failure to take HIV drugs as scheduled can encourage resistant strains of HIV. And that's one of the things that doctors will be sure, before they give HIV, patients with HIV, their medication, they have to be sure that they promise that they will take their medicine every day, all the time, never forget. Because if they forget or if they stop, it can come back with a vengeance. So failure to take HIV drugs as scheduled can encourage resistant strains of HIV. And then, sorry, but they're screwed because they just can't take anything else then. Nothing else is going to help them. There isn't that much to choose from to help them anyway. Now remember that what is the medication called that a patient with HIV takes? It's HAART, HAART, which stands for highly active antiretroviral therapy. So HIV infection has a patient with HIV gets prescribed HAART therapy. The nurse should warn the patient that if they don't take their drugs, it can come back and be resistant. So that's important. Page 575, you'll go to that. 575. Plasmapheresis. So when do you have, oh, that's not what I want. $575. Okay, so under signs and symptoms for thrombotic thrombocytopenic purpura, second column under signs and symptoms. No, I'm sorry, that's not where I want to take you. I'm sorry. Go back to thrombotic thrombocytopenic purpura. It's like the second paragraph. The main treatment for TTP, plasmapheresis. Now, if you have plasmapheresis, critically ill patients can become hemodynamically unstable during this procedure and need close monitoring and timely interventions to maintain cardiac output and blood pressure. You know, plasmapheresis where they exchange the blood, right? But they could get unstable. And especially if they're already critically ill, doesn't take much to push them over the edge. So if they're having plasmapheresis and they're a patient with TTP, they might become hypotensive. So the nurse has to watch carefully the vital signs. Okay. Let's go to page 573. And it talks about interventions. This is for a patient with leukemia. And we know that a patient with leukemia is at potential for injury or risk for infection. So that's where I am, intervention, potential for injury. Infection presents the greatest risk to patients with leukemia. Most hospitals institute compromised host and precautions when a patient's ANC falls below 1,000. But go down a little bit further, where it talks about uncooked foods. So because they are at risk for infection, we don't want potted plants in there. We don't want fruit that hasn't been washed properly. And uncooked foods naturally contain bacteria E. coli and Pseudomonas aeruginosa and Klebsiella. So a patient that's at risk from bacteria in their own body, and an example of that is, believe it or not, and it says it here in the book though, Pseudomonas aeruginosa. Right, that's their normal body internal bacteria. All right, let's go to page 570. Looks like the beginning of immunologic disorders. What is neutropenia? Neutropenia occurs when the total number of neutrophils is abnormally low. So that's important to know. Let me see. So if a patient on oncology unit is neutropenic, they are at risk for infection. Now remember, these questions are going to be worded a little bit differently. So just be sure you read the whole question. And know if it says visitors need to be free of infections before visiting patients, and especially chemotherapy and decreased bone marrow production patients, because why? Well, they're neutropenic. They can't fight off infections. So visitors are at a minimum for those patients. Okay, let's go to page now 631. Ooh, we're jumping. You'll find that the second 50 questions are probably be fresher in your mind. These are older questions. So that's a good thing, right? All right, 631. Did I say that? Yes. Page 631. This is, oh, you love this chapter, cardiac. That was a tough chapter, wasn't it? And you know, you're going to learn more and more as you start taking care of patients about these. You're getting your basic knowledge now, but to apply it, you're going to have to see it in action. So this is going to come in really handy when you start seeing your patients. So let's talk about cardioversion. That's actually on page 630, isn't it? And this is under common therapeutic measures for cardiac conditions. So usually a cardioversion is done for a patient with a dysrhythmia. They want to shock that dysrhythmia into a normal sinus rhythm. And so cardioversion is the delivery of a synchronized shock to terminate atrioventricular dysrhythmias. So the shock is synchronized with the R wave. This is the doctor's job. But your job, let's look at the next paragraph. It says, if the patient's receiving digoxin, the drug is withheld for 24 hours because digoxin already slows the heart. So this cardioversion is going to shock the heart and might slow it down. In fact, emergency drugs are usually available during a cardioversion just in case the heart goes too slow. So the patient has an IV line in case they need to use emergency drugs. And also, now think about it, you're going to get shocked. I'd like to be sedated for that. Thank you. Wouldn't you? So a short-acting sedative is usually given. So that's important to know. I hope you see that. That's like the second paragraph under cardioversion. So you're preparing the patient for a cardioversion and you're going to sedate them. All right. This is going to be the last one we're going to do for right now, and then I'll do more later. Let's turn to page 624. And it's a drug. We're going to talk about dopamine. So page 624, table 33.9, special medications for cardiovascular disorders. And let's go down to dopamine. Dopamine. So it's a inotropin is another name for it. So that tells you exactly what it's going to do. It's going to increase the blood pressure. It increases the cardiac output and the blood pressure. So whenever you've got a medication that increases the blood pressure, now dopamine is usually put, you monitor the patient's blood pressure and you increase or decrease the dopamine as needed to keep the blood pressure correct in a good range, whatever the doctor has ordered. But you want to watch out that that blood pressure doesn't go too high. That means your dopamine's dialed up too high. So be aware of any spike in the blood pressure because that could tell you that's a problem. Dopamine, we want to raise the blood pressure, but not too high because then we could get into more trouble with a stroke or something. So watch out for a spike in the blood pressure. So those patients are usually like a 1-to-1, we used to call them, because you've got to be there watching and titrating that dopamine for the needs of the patient. All right, guys, I'm going to stop here. That's number 50. We just went through 50 questions. So you can start reviewing these, and I will do the next 50 a little bit later. Thank you. Study hard.